It would seem that having consumers have exclusive or primary control over the records and portability, therefore, would eliminate incentives for healthcare providers to invest in record systems insofar as it's going to liberate the customer to go wherever. So the question is that a tension for you as a provider, a disincentive for you as a provider?
I don't really care who owns the data. You know, this data, I think, is going to be, and these systems are going to be ubiquitous in, I don't know, 6, 8, 10 years. And that this discussion right now about who controls the data, I think, is just really a short-lived discussion. The real issue is, are we building information systems that make clinical information available where clinical decisions are being made and where they would be influenced by the access to that information? And so I don't think and frankly, I know there's a lot of discussion, and I'm sure people on this panel would disagree with me. We have gone to great lengths to make sure that the information that we have is secure. It's obviously highly confidential information. But those people who use this system have become very comfortable with the use of this and recognize that the security of this information is just like the security of information that we take so for granted, whether it's our financial information or it's so many other kinds of information. So I think in the near term, these questions, who owns the data, how do you assure security of it, you know, are going to get debated. It's part of how you structure this process, but in the end, we're going to get over that. The real issue is how are clinical decisions made better because this information is available?
Barry, go ahead. So I'm a group health member, love the medical record that I have. I think it's, you know, really improves the care, and I think there's good metrics to show that. My question is, if I leave group health, what happens to that data? Right now, I don't see any way that that data comes with me. So I go into another city, you know, how do I get my data from group health?
Well, and I would say that that is a problem with our system. I wouldn't say that I want to control that information. I want to be part of a solution that makes that information transportable and accessible to you, whether you continue to be a group health member but get care outside of our group health care delivery system. We're going to get there. We have to get there. But it's not about control as far as I'm concerned. It's more about, you know, usability of that.
I can certainly say from our experience with HealthVault, these are exactly the kinds of questions we've addressed when discussing what HealthVault does for, say, Kaiser Permanente or Aetna. These are exactly the issues and challenges they're facing with their members. And in the case of Aetna, which is, you know, not a care delivery organization but has some similar concerns, one of the things they acknowledge up front is that their members are not going to be members for life. It's, you know, this is a society where we are highly mobile. There's a lot of business change, but at some point they might come back. So there's absolutely, you know, no reason why you couldn't give people continuity through allowing them to copy their records into something they control personally, like HealthVault or a similar platform for portability purposes.
No, I agree. You know, the systems are not interoperable. So no matter what you get nowadays, it appears that the systems don't talk to each other. So you don't have an ease of being able to send information from one provider to another. And I think it's what Microsoft's program, HealthVault, is trying to address. But I have a whole other issue. There isn't common standards for even the language to be used in health records. So it's very difficult if you're a consumer to understand what the doctor just said about you or what's in there. And you even have more substantial issues. For instance, the record may note that you had an image, an x-ray, but you don't know whether or not it was worth it. So I'll give an example, lower back pain. We found out through the Puget Sound Health Alliance that 90% of the people who had lower back pain were getting imaging. But imaging doesn't help you with lower back pain. It's a cash center for a hospital or a provider, but it isn't determinative in any way medically. So you would have in an electronic medical record, I was imaged with my lower back pain, but you wouldn't have, it was a worthless task, other than the fact that you would note that it was charged. So I want to separate the two. I think that the record is important. I appreciate the fact that right now I know I have a comprehensive set of information about me at one place. But I don't want that to be the issue of what we have to accomplish in terms of healthcare reform and efficiency and reducing waste, because there's a whole series of other things that we now have to do. My medical record and the record of my carriers should not be the vehicle we use to achieve healthcare reform in terms of efficiency. Transparency on the outside, and that is having public reports to me, are far more powerful. The issue is to develop a common language within all of those healthcare, those medical records. To have a common language, so therefore when you have a set of measurements as to what should have occurred, you can measure it more accurately than we can today. So I think it's medical records are the personal ones, are very, very important, but they're not the answer to healthcare reform. And I just needed to say that. There's a lot of other concerns I may have with them. For instance, people should be trained to use them. Our assumptions are banking records. But if we had banking records, we wouldn't have payday loans. And the reason why we have the payday system is there are a lot of people who are not very sophisticated with the technology, let alone what would be the content of it. So how do you use the record is really, really important. So you get all this data in front of you, and then you take pieces of it, then you go to the internet to see what it means, because it isn't self-explanatory as much as it should be. So we have a lot of work to do just in the personal record, but we should not rely on it as the answer to healthcare reform in this country.
John Hammarlund?
Barry, if I can address a little bit more the issue of the role of government versus the role of the private sector. I think Gail would agree that there is a role for the federal government in trying to help inspire interoperability, to help define standards, common standards, and to ensure and protect privacy and patient confidentiality. I mean, after all, the federal government is responsible for enforcing the Privacy Act and HIPAA laws, et cetera. But I don't think it's necessarily rests on the shoulders of the federal government at all, fully. I think we don't want to go to the other side where we say, caveat emptor, let the free market system completely determine this. On the other hand, it's not so clear that you necessarily want the government to come down from high and define all of the standards for the industry to comply with. Better that the federal government help set the table and define some of the parameters and bring all the great minds from private and public sectors together and see if we can build some consensus on standards and interoperability. And that's what we're trying to do at HHS. I also want to mention that, with respect to informed consumerism, Medicare does have a lot of websites of tools that are available to Medicare beneficiaries that allow them to find the right hospital for them, the right physician for them, the right home health agency for them, the right nursing home for them. And we get that information, of course, from our Medicare data, but it can be so much more enhanced if we had better health IT technology. Those consumer websites also play into the sorts of things that the Puget Sound Health Alliance is doing, where you can get a lot of rich information about the quality of care, the value, the volume, the cost of care, and consumers can make a lot of their own decisions about where they want to seek their care. So the sorts of things that we're doing in the government, in Medicare, in posting this information is very consistent with the work of the Puget Sound Health Alliance and other organizations like that.
Gail, I'd be interested in your point of view on this also as a very large provider.
Well, for VA, we're also a large payer. We purchase about $2 billion worth of care a year as well. So this interoperability is very important to us. So between VA, in collaboration with Kaiser and others, we do a lot in the area of standards and ensuring that in this horizon, of this 6 to 10 year horizon, that this information is available for the care we purchase or as veterans seek care outside. We also have a congressional mandate to make sure that as that serviceman or woman comes back, from the theater through Germany, back to Walter Reed or Bethesda, and into VA, and possibly back again, that's a seamless transition for them. But really, that should be an expectation for all of us, that our healthcare be that seamless. I think certainly we, those of us that are in a closed system, recognize that the incentives are quite counterintuitive today. When we don't do an extra test, we benefit from that. When we do post-market surveillance of new drugs and check their efficacy and monitor our formulary, we benefit from that. That's not something that you see in the private sector, nor, I think some of it's a consumer education aspect as well. We all want the latest and greatest drugs that are on the market, and I think there's a large consumer education aspect to that.